Hello and welcome to our topic for today. Very important topic, and that is the role of cytokines, the role of these mediators in the local inflammation and in at the system level, and if this inflammation is not rectified and remedied properly, how can the cytokines lead to shock, lead to systemic pathological effects? The triangle of shock, which is metabolic disturbances manifested by insulin resistance and hyperglycemia. That's the first side of the triangle. There will also be hypovolemia, a severe drop in blood pressure, leading to hypoperfusion and death of tissues due to lack of oxygen supply, lack of nutrient supply, and lack of toxic metabolic waste removal. So we have hypovolemia and we have hyperglycemia, and then we also have a hypercoagulable state manifested by disseminated intravascular coagulation, and this is the triad and the triangle of shock. This triangle of shock can manifest only through the cytokines. So we will briefly go over what do cytokines do in inflammation. Then we will talk about these cytokines. They are not only active at the site of the inflammation, but there are also systemic effects of inflammation. There are systemic effects exerted by these cytokines. You know, when someone is suffering from an inflammation, we don't go all the way down to the cellular level and the blood vessels and see are the endothelial cells retracting, are there interendothelial gaps, is there transmigration of the leukocytes, is there integrin stabilization of these leukocytes in the blood vessels. We don't look at the cellular level, but in fact we look at the systemic level. So we see there's fever. So fever is one of the systemic effects caused by cytokines during inflammation. We also have acute phase proteins where the liver secretes for us proteins like C-reactive protein, serum amyloid A, among other proteins, where we will see a state of systemic inflammation. And we will also see like leukopenia, where there's a severe increase in leukocyte production, this leukomoid state from the bone marrow. So we have to understand that that inflammation happens not only at the cellular and tissue level, but also at the system level. And if not remedied and rectified in time properly, we will move on to systemic pathological effects manifested as shock. Very important to understand the triangle of shock: hyperglycemia, which is caused by metabolic disturbances, insulin resistance, and lack of expression of these GLUT transporters that transport sugar from the blood into the cells and the tissues. And we also have disseminated intravascular coagulation caused by a hypercoagulable state. And we also have hypovolemia, severe drop in blood circulation. So let's review briefly. Okay, so where are we exactly? We talked about how we would have a normal cell. This normal cell would be in the state of homeostasis. And this state of homeostasis is a state where the cell, although is under severe noxious and stressful stimuli, and we talked about the different kinds of stressors and noxious stimuli that damage or injure the cell. We talked about ultraviolet radiation. We talked about infections, these infective microbes such as bacteria, such as viruses, fungi, and parasites. We talked about physical stimuli such as severe increase in temperature or severe drop in the temperature. We talked about chemical agents, corrosive agents. We talked about trauma like contusion, bruise, and so on and so forth. These are all stimuli that could damage the cell. But we also talked about how the cell is equipped with built-in control systems that enable the cell to fight back and overcome all of these noxious stimuli. However, if the stressful stimuli duration is long and if the intensity is severe, then what we will have is we will have a cell that is damaged and we will have an injured cell. If the injury is so severe, we would have an irreversible injury rather than a reversible injury. We would have an irreversible injury. And the irreversible injury would lead us either to cell death, either by apoptosis or necrosis. We wouldn't have inflammation if the cell dies by apoptosis. But when the cell dies through necrosis, we would have inflammation. And we talked about how if there is necrotic debris, if there is an infection, if there are infective agents like all of these microbes, we have talked about how there are resident sentinel immune cells known as mast cells, dendritic cells, and macrophages. And these cells, they have receptors that mechanically bind to lipopolysaccharides in the surfaces of these microbes to identify that yes, these are invading intruder damaging sources of harm. And there is also receptors. We talked about different kinds of receptors, and these are toll-like receptors and so on. And these receptors and the phagocytic receptors, these receptors bind to necrotic debris also and trigger intercellular cascades that releases these cytokines, and cytokines would recruit bigger immune cells from that are circulating inactively in our blood. And then the endothelium will also react to these cytokines by retracting, creating gaps between the endothelial cells, interendothelial gaps. Through these gaps, the white blood cells, the monocytes, which are macrophages, and polymorphonuclear cells, the neutrophils, will squeeze out through the endothelium and start to use their proteolytic degradative enzymes to degrade the extracellular matrix and walk properly to the site of the inflammation, to the site of inflammation, where they can engulf all of the necrotic debris and engulf all of these pathogens, degrade them using reactive oxidative species. And now we would pave the path for healing and resolution. Okay, I now want to talk about these cytokines and what they do. Okay, we already talked about how cytokines are increased in their expression, leading to expression of adhesion molecules, these integrants, leading to pro-inflammatory events. These pro-inflammatory events like interendothelial gaps, like vasodilation, increasing the permeability. And these cytokines are the interleukin 1 namely, and tumor necrosis factor. And these cells would leave the blood vessel and start to migrate to the site of the inflammation. We also have to know that tumor necrosis factor and interleukin 1 in the local inflammation, they activate leukocytes like the neutrophils and the macrophages. And these neutrophils and these macrophages lead to the expression of chemokines and other cytokines that in a positive feedback fashion, intensify the inflammatory response, where we would have an increased supply of white blood cells arriving to the site of the inflammation and doing the damage and destroying these cells. Okay, these invading cells. We also have interleukin 1 and interleukin 6. Interleukin 1 and interleukin 6, they influence T cells, and these are the lymphocytes. These T lymphocytes, we also have B lymphocytes affected by the cytokines, and they also release other cytokines. These other cytokines influence and bind to receptors of other cell types, leading to the secretion of chemokines. So this is a fashion where cytokines being secreted to mediate the inflammatory response. These cytokines bind to receptors of inflammatory cells. These inflammatory cells, in turn, once their receptors bind these signals, they themselves start secreting signals and cytokines that damage, cytokines that cause the recruitment of further supply or more supply of white blood cells to arrive at the site of the inflammation to combat these intruders and to engulf these microbes and engulf the necrotic debris and clear all the mess in order for the tissue to start healing and proliferating and to begin the process of resolution. Okay, so we talked about what happens with these cytokines at the site of the inflammation. But we also have to know that these cytokines, these mediators, they do not only mediate inflammation locally. In fact, when there is inflammation, we don't only have local events, we have systemic events. And the first systemic event I want to talk about is fever, which is an increase in temperature, in bodily temperature, from 1 to 4 degrees Celsius of the normal temperature. And what happens is these interleukins, these cytokines, they lead to the increasing in the expression of enzymes known as the cyclooxygenases. These cyclooxygenases create for us prostaglandins, namely prostacyclin and PEG2s. These prostaglandins, what they do is they travel to the hypothalamus, where they are now used in the hypothalamus, they are used to synthesize for us enzymes that reset the thermostat of the hypothalamus, and that leads to the fever event. And we also have to know that the liver is also involved. The brain is involved with fever, and the liver is involved. What does the liver do? The liver is responsible for acute phase proteins. These acute phase proteins are C-reactive protein and serum amyloid A protein. And C-reactive protein and serum amyloid proteins, these are proteins that are very important in mediating inflammation, where the entire blood circulation is now geared towards the site of inflammation. That's why clinically detectable serum amyloid protein, serum amyloid A and C-reactive protein are indicative, very indicative of so that means this patient is suffering from inflammation. And also in the blood, fibrinogen would lead to the cross-linking and creating of a hypercoagulable state. And that leads to erythrocyte sedimentation rate. So what happens is in erythrocyte sedimentation rate, patients who are suffering from the inflammation, there will be fibrinogen linked to these red blood cells, causing their deposition and sedimentation in a faster fashion than a rate where they are healthy and not suffering from inflammation. And The last thing I want to talk about is the bone marrow. And what happens in the bone marrow, there is increased during the times of inflammation, there is severely increased leukocyte production. There's a leukomoid reaction where tumor necrosis factor, interleukin 1 and interleukin 6 cause the exuberant production of white blood cells, because now the body is suffering from inflammation and needs this supply of immune cells, this supply of immune cells, that this supply of defensive white blood cells, neutrophils, where we have neutrophilia in the case of bacterial infection, or we will have an increase in the number of lymphocytes with certain viruses, and with other viruses we'll have a drop in lymphocytes. That shows you where these in lymphocytes and where are these neutrophils coming from. They are coming from an increased production of white blood cells. That's why patients who have leukopenia, which is a severe increase in the number of white blood cells in the blood, leukopenia indicates a systemic event of inflammation. So leukopenia caused by the bone marrow, acute phase proteins, C-reactive protein, we talked about erythrocyte sedimentation rate and serum amyloid A from the liver. And the liver starts doing that when the interleukin 1 and interleukin 6 in inflammation go to the liver, and they cause acute phase proteins to be secreted in inflammation. And tumor necrosis factor, interleukin 1, interleukin 6 go to the bone marrow to increase for us leukocyte production, and interleukin 1, interleukin 6 go to the hypothalamus and increase the thermostat and cause fever. That's a systemic protective event. Now let's talk about pathologically what may happen if this inflammation is not rectified. What happens is, first of all, we would have hypovolemia. This is supposedly the heart. We would have hypovolemia, where there is a drop, there's low output, where tumor necrosis factor would go to the heart, and other cytokines would lead to low cardiac output. Low cardiac output, not enough blood due to the vasodilation. So when we increase the vasodilation during inflammation, the inflammation promotes vasodilation. So this vasodilation causes a drop in the blood pressure. This drop in the blood pressure, if not remedied and rectified in time, would cause hypovolemia. Hypovolemia, there is severely low cardiac output. That means there is not enough supply of oxygen, there is no enough supply of nutrients, there is not enough blood that would come and wash out and remove metabolic waste and toxins in the tissues. That would lead to ischemia and death of these tissues. So that's the first side of the triangle, hypovolemia. So now you know how cytokines cause the hypovolemia. The other thing that the cytokines cause is the hypercoagulable state, where the cytokines promote a state of hypercoagulability, leading to the cross-linking of these these red blood cells and other platelets to cause for us a thrombus. And there will be disseminated intravascular coagulation. And this disseminated intravascular coagulation caused by hypercoagulable state, that is the second side of our triangle. And that is a manifestation caused, a clinical manifestation caused by inflammation. So the cytokines would promote a hypercoagulable state, and that hypercoagulable state will lead to the formation of disseminated intravascular coagulation. And then we would have a metabolic disturbance, and the metabolic disturbance is the cytokines would interfere with the expression of the GLUT transporters that would take in the cells, the glucose from the blood into the tissues. The cytokines during inflammation also cause a state of insulin resistance, and these insulin resistance causes hyperglycemia, and that is the third side of our triangle. Now we would have hypovolemia, we would have During inflammation, cytokines causing hypovolemia, low cardiac output. Cytokines will also cause disseminated intravascular coagulation, hypercoagulable state, and then in the end we would have skeletal muscle. In the skeletal muscles, these storage sites of insulin, storage sites of glycogen, we would now have insulin resistance causing hyperglycemia. So metabolic disturbances, so cytokines causing metabolic disturbances, causing hypovolemia, causing hypercoagulable state, leading to a state of shock, and that is a systemic pathological manifestation of cytokines. So these cytokines, they initially begin to exert local effects to propagate inflammation, and then they start to reflect at the systemic level, and if not remedied at the systemic level, where we would have fever, we would have leukopenia, where we would have acute phase proteins, then we would have, after all of that, we would have, we would move on towards the shock. So please review, and I'll see you in our next video. Thank you very much. Okay, the last thing I want to talk to you about is the chemokines. And we said that secretion of chemokines are a special class of cytokines where they promote, once they bind to the receptors on the white blood cells, when chemokines are secreted by white blood cells and they go and bind receptors on other white blood cells, these chemokines will trigger cytoskeletal rearrangements, and there will be architectural rearrangement where the cells will start to chemotaxis, which is movement towards chemical gradient, where we would have actin and myosin filaments mechanically propagating and pushing the cell at the sites where the receptors binded chemokine signals, and they will move toward that direction physically, and we will now have chemotaxis. So please review, and I'll see you in our next video.